I'll invite the chairpersons of the next session, Dr. Harsh, Dr. Chandrima Paul, Dr. Sushmita Kaushik, Dr. Sirisha Senthil, Dr. Thomas George, Dr. Vinita, and Dr. K. Subhashini. Great. Yeah. And Dr. Sachin, yeah.
Yeah. Start without. Okay. Thank you, Dr. Amit, for having me here. As we are late, I would just wind up the talk with a few points and a summary to close it off. So the topic is about angle closure disease and its management. At the outset, we would welcome you all to Mumbai and hope you are having a good time. So, as we know, we have classification of angle closure into primary and secondary angle closure, which is pretty basic and we all know about it. I will be just going through the very salient points because we don't have time. And it's in a population-based study with esteemed faculty that we have here. They have done it themselves. It's around 0.5 to 1.9% of the population. Blindness, though, is carrying a threefold higher risk than that of open-angle glaucoma. The important thing that we should know is iridotrabecular contact in any form compromises the meshwork function, and there is no way to know how much of meshwork function is compromised, and changes in outflow facility manifest as IOP spikes, larger DVs that need to be picked up early. Chronic PACGIs progressed earlier and faster according to studies by our own teacher Ciota et al. And they progress much faster than open angle glaucomas. We have the common ISGO study staging of the disease where we know that it's a more practical explanation of the angle structures, which is divided into PACS, PAC, PACG and acute episode of angle closure attack. This explains the prognosis and the management better, whereas the age-old classification of glaucoma explains the symptomatology and clinical findings better. That is the angle closure suspect, acute angle closure, intermittent, chronic and status post-acute attack. Now the symptoms we all know, symptomatic angle closure is always an acute angle closure. Otherwise, it's basically asymptomatic disease manifest with repeated blurred vision and changes in refraction. And status post-acute attack, we can see some things like flecken, pupil abnormalities and disc pallor. Now, important thing is pupillary block is the most important theory according to Mapstone and constitutes 75% of the cases, and the rest are due to the ciliary body abnormalities, lens-induced abnormalities behind the lens, and they are precipitated by dim light accommodation, stress, dilatation of the pupil, etc. There can be more than one mechanism at play at one time. That is what we should know. Investigations of glaucoma are pretty common, but remember that gonioscopy is the holy grail, and more so in case of angle closure disease. Apart from that, a point about provocative test, it's historical with no role, and they put the patient at the risk of angle closure in predisposed eyes, and the sensitivity is poor. OCT angiography does give us a nugget of information which I shall just show you. And ASOCT and UBM are in specific situations like plateau iris, cysts, malignant glaucoma, and drug induced. We can use them on a per case basis. Gonioscopy is the cornerstone. We know all how important gonioscopy is. Knowing the importance of the corneal wedge, indentation gonioscopy is very, very important. What we should always know that on every follow-up we should document meshwork progression, inter-eye asymmetry and new areas of pass. That is what we call as gonio progression, which people don't talk about as commonly as progression in the fields and perimetry and OCT. Pigmented Schwalbe's line is one of the common sources of error. So use indentation and corneal wedge to identify it so that that mistake is avoided. Variations in pigmentation in single eye also occur. Temporal and nasal angles are pretty tricky to identify because of the difficulty in getting a corneal wedge there. But always remember that pigmentation over the angle should be closely documented, and blotchy pigmentation is a telltale sign of iridotrabecular contact. Now, which angles stay closed is very important, because after PI we feel that all angles open, but there are certain angles with thicker iris insertion, thicker iris itself, plateau iris, large lens and smaller anterior segment, and all iridotomies do not open a narrow angle. Their primary role is to prevent pupillary block. That is something that we should always remember. After these studies with the UBM and ASOCT, many things of these were clear, and you know that now the iris can be inserted in various ways. It has various configurations, various thickness, And there are some things called as relative anterior microphthalmos, and all these cases have their own implications in angle closure and the role of iridotomy. Lens vault, anterior segment biometry and iris patterns, and also ciliary body and iris imaging have thrown light on various mechanisms of angle closure that can be refractory to iridotomy opening the angle. OCT angiography and macular ganglion cell complex have thrown up interesting findings about angle closure disease because they cause acute ischemia. The amount of capillary dropout that occurs suddenly after an acute pressure elevation is something which we found out, which we had presented in one of the 2 meets of the GSI, and immediately post-operatively, you can't find that out on clinical examination. The disc pallor sets in late, but the changes on the ganglion cells are pretty immediate, and you could find that out as early as 2 to 3 weeks post acute attack. That is something we should keep in mind. Something like this, when the disc appears pale, the RNFL is still decaying, but the field is like this. Such cases cannot be explained by anything except the loss of the RPCs, which is very acute following a acute elevation of intraocular pressure. So a nugget about these new investigations. Similarly, here also you can see acute elevation of IOP. Everything else appears okay except the loss of the macular ganglion cells in the superior part. One more case which shows the same finding here. RNFL relatively preserved better than the ganglion cell complex after an acute elevation of IOP. Field effects vary in angle closure disease because of the ischemic damage. There is no pattern in acute angle closure, but definitely chronic angle closure mimics open angle glaucoma. So we find the whole gamut of changes, and that will depend upon the pathophysiology of IOP variation. So it depends on duration of pressure elevation and can manifest also in a few months. Misdiagnosis of PACG is common. The expertise in gonioscopy is of paramount importance. You should repeat regularly, repeat post-PI, and repeat if in doubt without any ego. Treatment is, first line in primary glaucoma is laser PI. You don't laser all PACS, but with family history, poor follow-up, fellow eye of PAC requiring routine dilatation, our patient has gonio progression, or a patient is one-eyed. All PACS plus OHT, PAC and PACG except the ones with total PAS who may not benefit. Post-PI, 59% still have very persistent ITC on UBM, so we cannot forget post-PI gonioscopy and can't assume angle opening. This is something we should remember. Medical management, associated ocular hypertension can be managed by all the medications which we use for open angle glaucoma, but don't forget the poor pilocarpine. In some people who tolerate it well, it does well in cases of thicker iris and in plateau iris configuration. So those candidates who don't have any contraindication, you can use pilocarpine also. And in acute attack, definitely have hyperosmotics, paracentesis, the role of which is now heightened after the knowledge of ganglion cell loss in acute pressure elevation, and iridoplasty, PI as per it, appropriate, and medical management with or without trabeculectomy depending upon the decay of the intraocular pressure. Laser iridoplasty is something that we should know. In those willing or have side effects of pilocarpine, iridoplasty can be considered in cases of plateau iris or thick peripheral iris rolls. And simple procedure, energy titration and effect on pupil to be taken into account. It should be told to the patient in no uncertain terms, can distort the pupil to some extent. And you repeat the gonio post-PI and post-IP and reassess on the cases. Again, don't assume angle opening. Surgical management with concomitant cataract. Early glaucoma with good IOP control, you can do cataract alone. It will do well for pressure control. Moderate glaucoma with IOP within targets, again cataract alone. Advanced glaucoma, trabeculectomy alone or phaco trap depends on the skill expertise of the individual surgeon. Phaco done later after trabeculectomy can lead to filtration failure, so that is to be remembered. And it can be also combined if poor follow-up is expected. Trab alone can be done in uncontrolled glaucoma with advanced glaucoma. Target IOP is not achieved by medications or allergic to drugs. Counsel the patient well, use pre-op hyperosmotics, releasable suture is the norm. Watch for aqueous misdirection in such cases without fail. Drainage implants have a role in secondary angle closure like neovascular glaucomas, where you can put the tube in the ciliary sulcus, and they do well. Such patients with active neovascularization and suboptimal laser definitely will do better with drainage implants as compared to trabeculectomy. Eagle study and role of goniosinoculitis is debatable. Eagle study has its own limitations. To consider early lens extraction in all cases of angle closure, not recommended because there is not enough evidence and too many data gaps. Goniosinoculitis on date has not demonstrated significant clinical benefit to be considered the standard of care. So take-home messages, always come to a complete diagnosis, classify angle closure disease according to ISGO classification. Remember, it's often misdiagnosed. Gonioscopy and gonioscopy is important. No ego, when in doubt, repeat gonioscopy. Use UBM ASOCT in appropriate situations. Laser PI is the cornerstone of management. Do not forget poor pilocarpine in ideal cases, and trabeculectomy with releasable sutures is a safer option with an with an eye for aqueous misdirection. Thank you so much.
Thank you, Dr. Sachin. Very nicely covered in such a short time. Can I have one quick comment from Dr. Sirisha on this? Because of paucity of time, I'll request just one comment from each of the panelists.
Yeah, I think Sachin, you've done a wonderful job, covered as much as possible, and I don't have anything additional to add. Maybe one point is in the presence of excess vault of the lens. That is one other mechanism which we are seeing these days. Yeah. So early cataract itself, we would possibly be pushed towards doing a cataract extraction. Not, of course, not a clear lens study, but so although you don't take home the clear lens extraction from the EAGLE study, but definitely an early cataract would be an option to remove in these cases, and that will be helpful. Thank you. It's available from today. It's available from today.
That's great.
We'll have to do something for Mumbai then.
No, it's available. So in fact, we were getting it from Maharashtra.
Okay.
So what we started doing is pilocarpine carpinol that is available as ampules. So that is 0.5% carpinol, which is preservative free. So open up 2 or 3 bottles of that and put it in a preservative, whatever the tear lubricant bottle in a sterile way, and let the patient, because we first used it for our PI patients, because when we ran out, we used it as a pre-eye measure, and we found that the pupil constricted, we were able to do a PI. Only then we started dispensing it. This is in desperate situations, but obviously you can't have a label. 3 or 4 ampules, 5 ml, because each one is 1 ml. So you can add 3 or 4 ampules. No, nothing. It's only 0.5%.
Meat itself is less than what we
Yeah, it's only 0.5.
It's 0.5%.
But it's working because we checked it. Right. We checked it for PI patients, it worked, and that's how we started giving it in desperate situations.
That's an excellent tip. Now I'll request Dr. Pankaj to deliver his talk on evaluation of a case of pediatric glaucoma. You have to cut down your talk by 1 minute.
Yes. Thank you, sir. Thank you. I first thanks Amit sir for involving me in this session. Yes, so congenital glaucoma is a topic after yesterday's good session by Mandal sir. Congenital glaucoma and developmental glaucomas are associated with syndromes and systemic abnormalities are the primary glaucomas. Secondary glaucomas are because of the post-cataract surgery. These are the lesser categories. And the common syndromes they are associated are Sturge-Weber, oculos, cerebrorenal syndrome, Axenfeld-Riekel, and neurofibromatosis. So there can be a variation at presentation because of at what time the IOP started rising, because clearly elasticity is there for first 2 years of life. So gradually increasing pressure can result in little or no corneal clouding. Patients with sudden rise in pressure can present with the corneal clouding. Progressive myopia, increasing axial length and changing corneal diameter in the face of borderline IOP, and cupping is a suggestive of high pressures. And and children with more than 3 years of age, changes associated with ophthalmos become less apparent because of decreased elasticity. So IOP measurement is an important factor for the pediatric glaucoma, and obtaining IOP measurement in children itself is a challenging thing. Current methods include rebound tonometry, eye care, handheld Perkins tonometer. These are the common practice. Rebound tonometry has the advantage of not requiring anesthetic drops. However, child must be upright, and also there is a tendency to overestimate IOP. Eye Care Pro is the one that can be used in all positions, and Perkin is a standard that can be used in all the positions. So EUA is a must for most of the patients, and as per your setup, you can have a lot of things in the EUA, including the IOP measurement as soon as the anesthetic agents are given or the child is sedated, CCT evaluation, corneal thickness and anterior segment examination, gonioscopy, fundoscopy with ONH photograph if you have a portable fundus camera, refraction, axial length measurement, and B-scan and UBM if required in some of the cases. So the most important thing is challenges in the IOP measurements. Normal IOP in infants around 10 to 15 under anesthesia. If an examination under anesthesia is needed, IOP should be measured as soon as possible after anesthesia is induced. Optimal IOP measurements are obtained in the office because IOP is usually lowered by the anesthetic agents and the sedative. In contrast, other medication like ketamine and succinylcholine can increase the IOP, and crying, screaming also can increase the IOP. So in children who are older but still 4 to 5 years of age, portable Perkins can be a good thing. And slit lamp Goldman is always best when patients are up to 4 to 5 years of age and above that. Pachymetry has no direct relations like adults, but we should know that some of the congenital glaucomas, they can have the higher pachy. Normal pachy in adults is around 537 microns, and it can vary from 427 to 620. In normal children, it doesn't vary significantly with age. CCT appears to be similar in normal children and those with PCG, but except few of the glaucomas like aphakic glaucoma, Sturge-Weber syndrome, aniridia, microcornea, where there can be a very thick pachy and they will affect the IOP readings. Corneal diameter normally around 9.5 to 10.5, and ophthalmic eyes definitely they are more and up, more than even 12 millimeters in the first year of life. Gonioscopy, either you can do with Cope's lens, or even if you have then the Goldman lens, or even the direct surgical gonio lens. With that also you can do the gonioscopy to find out how the angle structures are. ONH documentation is a very important part. Photographic documentation is definitely good if you have portable fundus camera. Glaucomatous cupping behaves slightly differently in the children because of scleral elasticity. So glaucomatous cupping in children is characterized by preferential loss of neuroidal rim tissues in both superior and inferior poles and enlargement of scleral canal. Scleral canal enlargement is a unique to pediatric glaucoma and may cause cupping without significant neural tissue loss. So the approach should be medical management only as a stopover till the surgery is patients are prepared for surgery. As a only supplementary, timolol, dorzolamide are the commonly used, and surgical options depends on the stage of glaucoma, corneal clarity. So goniotomy if cornea is clear, or otherwise trabeculotomy, trap plus trap, as the Mandal Sarva yesterday was saying, was the best surgery. Shunt surgeries and cyclorestrictive procedures, they come in the picture as per the cases. So prevention of amblyopia, this is the last slide. That is the most important thing, because refractive error needs to be treated as early as possible in order to prevent the amblyopia. Myopia due to increasing axial length, ophthalmos and astigmatism due to half stria. In fact, amblyopia is the one of the issue where people suffer because of that. So visual outcome vary. Vision at the time of diagnosis, type of glaucoma, amblyopia are the important determinants, and children with primary congenital glaucoma have the best prognosis. In the setting of well-controlled pressures, amblyopia is a key factor in the vision loss. Thank you. Yes. No, sir. Yesterday we had a good IC when Mandal sir has explained everything in detail, I guess, and this was just the juice of it or summary of it. So this is the slide. I think that the vision at the time of diagnosis, type of glaucoma, at presentation, that's what are long-term determinants. And don't forget amblyopia, because by controlling glaucoma, you will not solve all the issues. Focus on the refraction and good amount of amblyopia, good team approach, as Mandal sir was saying yesterday, pediatric ophthalm, that will do well.
I think it was a wonderful presentation, and being Mandal sir's brief version, there's really nothing to add to it, basically. I think he's covered up everything that one needs to know. If anybody has a question, then of course, yeah. Absolutely, yes. Yes. He's covered all the points that one needs to know.
Yeah, I think pinch hitter role.
So the next all 4 presentations are case presentations of 3 minutes each. So one detail.
A very good afternoon to the esteemed faculty present in the audience as well as on the dais. I am Dr. Talveer Sidhu. I am going to present a case presentation, a very short case presentation on normal tension glaucoma. Although in my personal patients, I did not have a very long follow-up of a normal tension glaucoma, although I'm following up quite a few number of normal tension. This was a case that was published in AIOS, the guidelines that were taken out for open angle glaucoma 2-3 years back. So this case was of a 40-year-old female who had a history of headache, and the intraocular pressures, while they were in a very normal range, the optic discs, as we can see here, were had RNFL defects in the superior and in the inferior quadrants, both in both the eyes, with a disc hemorrhage that is present in the left eye. And the visual fields, they were as such, as shown here in the right eye. There was a inferior arcuate scotoma and a nasal step in the left eye, which was almost about to become an arcuate. So diagnosis is usually very obvious in normal tension glaucomas, and visual fields when they present are very close to the fixation and quite inside the Jerem's area as they present. And the management, as has been already described, that 30% of intraocular pressure reduction has been suggested by the collaborative normal tension glaucoma study. And the target IOP that was actually thought about in this patient was around 10 to 12 millimeter of mercury. And for that, the patient was prescribed latanoprost in both the eyes. And after 4 weeks, the IOP was found to be 12 to 14. In a long-term follow-up, it was found that the person, this patient did not progress in the right eye, while in the left eye, there was likely progression in 3 or 4 points as shown in the picture below, and we can see that there are shaded triangles that are present quite near to the fixation, which were not present in the initial visual fields of the patient. And these are also just like in the normal tension glaucomas, very typical close to fixation visual field defects are present. The intraocular pressure in long term was found to be 12 to 14 and 12 to 16. While the patient was also under treatment for migraine, and the patient was actually, this lady had migraine. So this is a case presentation. I have actually left very many open-ended questions in this case report, which can be addressed in the discussion, that how these people, how the patients with normal tension glaucoma, they can progress, and a very good follow-up in normal tension glaucoma patients is needed. Thank you very much.
To say that 40 years is a pretty early age for NTG to present, and secondly, one should rule out POAG by doing a diurnal variation. Sometimes they behave like NTG, but basically they are POAG. But then this patient had a central field loss, which is more common in NTG. But even nowadays, the reports are coming that 10-2 fields has to be done, because central scotomas are more common in POAG patients also. So this could be a progressing type of an NTG, because NTG per se is a slowly progressing disorder, and it may be associated with multiple factors, and in this case the migraine was the associated factor.
I'll request Dr. Neha Mehta. She is going to give a case presentation on steroid-induced glaucoma.
A very good afternoon to esteemed faculty members and dear friends in the audience. So I'll be talking about a very simple history-based case on steroid-induced glaucoma. So typically when a patient comes to my OPD and has high intraocular pressures and I want to rule out steroid use, this is my typical questionnaire when I'll ask them if you have any other history of any eye infection for which you have used medications, any history of over-the-counter medication, any asthma, nebulizer, inhaler, any skin issue for which they are using cream, any scalp problem, any illness for which they are on long-term medication, or any desi dawai, churan or pill without a wrapper that they are taking without, without a physician's consult, or any other problem. So this is my typical questionnaire. So coming to my case, he was a 34-year-old male badminton player, was diagnosed with ulcerative colitis at the age of 31 years. He was started on Predmet 60 mg, used for 8 weeks, started complaining of cloudy vision, when on examination was found to have intraocular pressures of 52 and 48 with a healthy optic nerve head. Responded well to medical management. Within 4 weeks of starting anti-glaucoma treatment and tapering steroids, he was maintaining intraocular pressure in mid-teens on 3 medications. A year later, he developed itching, redness, was treated with loteprednol LS, BD for 2 weeks, again gave a history that his IOP shot to 32-34. In both eyes, again steroids were tapered, medical management again increased, eventually again got the IOP back in mid-teens. The patient presented to me for the first time in June 2021 for a second opinion and also with complaints of itching and watering. IOP was well controlled on brinzotimo and travoprost. The patient was started on lubricants and olopatadine. July was all okay. In October, the IOP again was okay. However, the patient was complaining of increased allergy. I offered him a short course of FML BD for 7 days only, but patient was obviously very educated, well aware, and said, no, I would bear the allergy, but I do not want even a short course of steroid. I said, fine. I also started the patient eventually on cyclomune 0.1%. Patient then again came on 12th of November. IOP was okay. Allergy had even aggravated further. He had a tournament to attend and wanted immediate relief anyhow. So I gave loteprednol, TDS on day 1, BD on day 2, OD on day 3, and LS on day 4, day 5. Only 10 drops over the 5 days. 17th November, IOP had shot up to 26. I could not add any more topical medication. Patient was allergic to brimonidine. Then on 25th November, again the IOP was still higher. I was still observing that, since the disc was healthy, IOP that day was 25, 26. 4th December, the steroids had already been stopped about 10 days back, but the IOP today was 30, 32. I could not explain. I asked my questionnaire again if there was something else differently that he was doing. So he said nothing, and then 4th December night, he went back home and called me that, ma'am, I was applying clobetasone cream to my son for an exacerbation of atopic dermatitis. Is it because of that? So here was the clinching diagnosis. So he was having transcutaneous absorption while he was massaging the clobetasone onto his son's skin. So I asked him to stop immediately and get the IOP checked for son also. So 14 December, eventually I followed up when the steroids when he stopped using that cream. The IOP came back to normal. It took about 6 weeks for the effect to wane off. So this case added to my questionnaire list that I also have to ask if you're applying steroids to somebody else in your family. Thank you.
That was very interesting case. So we really have to look for the culprit. See, here the culprit was not the steroid application onto the patient, but indirect steroid absorption by the skin cream which he was applying onto his son. Yes, sir. Dr. Thomas George for quick comment on this, sir.
Anyway, that was a very good build up to the final climax. I was wondering how lotipanol can cause this much. Anyway, that's a good piece of GK for all of us to look at. It could be any steroid. When you have a high pressure, very high pressure especially, you have to think of some steroid intake some way. And quite often Ayurvedic medicines, they have this adulteration going on also. And that's to be underlined.
Sorry, just to add one thing, anabolic steroids, somebody is going to the gym. And he's taking anabolic steroids. They may not tell you, but it's just that concoction that your trainer gives. So that is also one more additional question you can ask.
Also drugs for flares. These are all, they're given things for
High protein, yeah, in the gym.
Same for the gym.
So now I'll request Dr. Sonika. She is going to give a case presentation on lens-induced glaucoma. Dr. Sonika.
Yeah, good afternoon one and all. Thank you guys for this opportunity. So I'll start with a case. It's a 75-year-old lady presented with history of headache since 5 days to a family physician and was evaluated for the same. 2 days later, she developed left eye pain and redness, for which an ophthalmology consultation was taken. She had history of poor vision in the left eye since a year and a past history of right eye surgery 10 years back. No history of trauma, left eye surgery or previous such episodes. Right eye on examination, right eye just showed a posterior chamber IOL. Left eye, there was PL present with PR inaccurate. Circumciliary congestion. Cornea showed edema with no KPs. The anterior chamber was deep with cells and flare with the presence of whitish material in the anterior chamber. There was RAPD with a hypermature cataract. The IOP on applanation was around 60 millimeters of mercury with no view to the posterior segment. The B scan showed few vitreous opacities just posterior to the posterior capsule with no other opacities or abnormities. So a diagnosis of phacolytic glaucoma was made. Now before coming to a diagnosis, we should keep differentials in mind like open angle glaucoma with uveitis, but lack of no KPs with a hypermature cataract goes in more favor of phacolytic glaucoma. Lens particle glaucoma, ask for history of surgeries or any injury. Acute angle closure glaucoma, the anterior chamber depth will give you an idea. And the glaucoma associated with trauma. Management, this patient mainly, the IOP was lowered with topical and oral anti-glaucoma medications and topical steroids and cycloplegics were started. Pre-op mannitol was given and a manual small incision with IOL was done. Post-operative follow-up was good enough. By 8 weeks, the vision was around 6.9. The vitreous opacities has resolved and IOP was around 17 millimeter of mercury. Now what do we learn? Patients with lens-induced glaucoma may present to a physician for headache and vomiting and can be evaluated for other cases rather than ocular till they develop redness pain. Though PR inaccurate doesn't mean that patient will not improve his vision. Under guided prognosis, perform a lens extraction to relieve pain or inflammation at least. Now about the anti-vitreous opacities, many surgeons, they do a partial vitrectomy for rapid visualization. But these anti-vitreous opacities are self-resolving in phacolytic glaucoma in around 8 to 12 weeks. The surgical dilemmas here is when we ask whether we will do a ECC, or SICS or phaco, which is the best. Now, there are many studies which have shown SICS being a good one, but phaco is also good, and the problems are mainly corneal edema and a capsule status. So finally, it depends upon the surgeon's experience and comfort. Now, last question is whether to go for when to go for a combined surgery in such cases. There are studies which have shown that one study shows mainly a duration of around, if the symptoms are less than 2 to 3 weeks, then just cataract extraction will give you a good result. There's another study done at CMC where the duration of more than 7 days and IOP uncontrolled, even on maximum medical management, they did a cataract extraction with a trab. I think because of lack of time, I would stop here. Thank you.
Thank you. Thank you, Dr. Sonika. I'll request Dr. Subhashini to give a comment on this case of lens-induced glaucoma.
Yeah, that was a good presentation on phacolytic, and you didn't move into phacomorphic, no? You also had a case on that. Yeah, phacolytic glaucoma mostly can be, the definitive management is lens extraction, and in these cases, most of the cases will not require an additional trabeculectomy surgery for control of the pressures. And actually those vitreous opacities, it's actually the fluidic lens matter which is found over the anterior vitreous face, so which gets absorbed over time, or some people even make a nick in the PC to just take out that liquefied lens matter. So either way, it's fine, but it's more than opacities, it's over the anterior vitreous face. Thank you.
Thank you. The last talk is on neovascular glaucoma, case presentation by Dr. Jaswant. Is he there, Dr. Jaswant? Yeah, please.
This last one. I would like to thank AIOS and the organizing committee too for having me here. So my talk will be on a case of neovascular glaucoma. This 64 years old male, he was already under treatment with us for proliferative diabetic retinopathy. The right eye he had already lost because of neovascular glaucoma, and he was lost to follow-up and again reviewed with us about 6 or 7 months later with a best corrected visual acuity of 6/36 in the left eye. The intraocular pressure with GAT was 45 millimeters of mercury on 4 topical AGMs. Gonioscopy showed open angles, and we could see the neovascularization that was present near the pupillary margin. The posterior pole showed attached retina with the laser scars and a cup disc ratio with showing advanced disc damage. So the patient was started on tablet astazolamide half BD because he was hemodynamically unstable and his blood sugars were uncontrolled. So he was also started on a fixed dose combination along with the PG analogs and steroid eye drops topically 6 times daily. And he was planned for left eye intracameral Avastin followed by a glaucoma valve implantation. 1 week after the intracameral injection of Avastin, his best corrected visual acuity was 5/60 and NVI was noted to regress. The intraocular pressure, however, remained 40 millimeters of mercury. This is the post-op day 1 photograph showing shown after an AGV implantation, showing relatively regressing NVI and a BCVA of hand movement and intraocular pressure of 5 millimeters of mercury. The patient followed up for another 13 months, and when he was noted to have a best corrected visual acuity of 6/60 and an intraocular pressure of 14 on brimonidine and timolol combination, and this was his visual field that we got. However, this patient again followed up recently last month with a visual acuity of hand movement, and we could see recurrence of this neovascularization along with vitreous hemorrhage. However, the intraocular pressure remained 20 millimeters of mercury with applanation. Thank you.
Thank you. Thank you for sticking to time and presenting such a wonderful case. Dr. Chandrima ma'am, for a quick comment on this case.
Yeah, that was a really good presentation. A couple of points. That is, number one is that all diabetics, please do a gonioscopy, because proliferative diabetic retinopathy could be first detected with your gonioscope by angle neovascularization. So that's very important. And number two is that when you have rubeosis already, yeah, please think of giving an anti-VEGF, whether it's bevacizumab or ranibizumab, and followed by whatever you do. You always can do trabeculectomy. After you give the ranibizumab or the bevacizumab, wait for a week, the vessels generally regress, then you can do a trabeculectomy, or if you plan to do a valve, you can do a valve 1 week after you've given an anti-VEGF.
Can I just add a point, please?
One point to be added, that the cause has to be treated. Until unless you don't treat the cause, the neovascularization will go, but then the glaucoma will not settle. So if it is CRVO or diabetic retinopathy, we have to do an angiography and find out and do the lasers.
Exactly,
So
yeah.
the treatment is not only glaucoma treatment, it is the treatment of the cause which is causing the ischemia and neovascularization that has to be taken care of.
Exactly, like there was a recurrence of neovascularization and the pressure again shot up to 20 millimeter of mercury. So what I think is the predisposing cause, whether it was venous occlusion or diabetic retinopathy, that should also have been, I think, included in the management, like you did PRP or intravitreal anti-VEGF, whatever it is. So that treatment is required so that these cases can be tackled much more comprehensively. So I think with that we come to the end of.
Can I add a point, please?
Yeah, please.
A very important point. When glaucoma valve is done, the post-operative pressure has to be monitored very closely. And if it starts rising to mid-teens, one should start using aqueous suppressants at that point and not wait for the pressure to rise to 40 before you restart medication. That way you will find that long term, possibly your AGV will survive better. Thanks.
Thank you. So we got the session 15 minutes late, but we have finished 10 minutes earlier. I think credit to all the chairpersons.
Thank you, chairpersons. Before I start the next session, a quick photograph of the current session speakers and the chairperson. Now I invite the next chairperson officials, Dr. Madhu Bhaduria, ma'am.